Good morning, sir. We will start the session in next 10 minutes, sir. I welcome you, and we'll just wait for 10 minutes before we start the session, sir. Thank you so much for accepting.
Hi, can you do me a favor? Just ping
Yes,
me
sir.
before you're ready to start. I'm still seeing a couple of patients, so just ping me before you start.
True, sir. True. I'll do that. In another 5 minutes, I will ping you, sir. Thank you so much.
ಆಡಿ ಇದು ಬರ್ತಾ ಇಲ್ಲ.
Good morning, everybody. We will be starting off with the session in a short while.
Please wait.
Good morning, everybody. On behalf of University Center for Health Professions Education, Sri Devaraja's Academy of Higher Education and Research, Kolar, I cordially welcome one and all for this webinar on effective clinical teaching in new normal by Professor Dr. Krishna G. Seshadri. It's my privilege to welcome Professor Dr. Krishna G. Seshadri to this webinar. Sir has graduated from Madras Medical College, after which he pursued his post-graduation in the United States as a resident in internal medicine at Illinois Masonic Medical Center, Chicago, and proceeded to complete his fellowship in endocrinology at the Cook County Hospital, Chicago. He has obtained his American board certification in internal medicine, endocrinology, diabetes, and metabolism. In the year 1996, he was appointed as lecturer in the University of Illinois College of Medicine. He joined Sri Ramachandra University in 1997, and at the time of leaving the university, he was professor of internal medicine and professor and head of endocrinology and diabetes. He is the visiting professor of endocrinology and medical education and member, board of management and consultant to management, Sri Balaji Vidyapeeth and its constituent colleges. He is currently senior consultant in endocrinology and diabetes in Apollo Hospitals and senior clinical and research lead Apollo Sagar. He is director of Primer, a medical education company, and PAMS, a not-for-profit medical organization. Sir runs a boutique practice of endocrinology and diabetes called Chennai Diabetes and Endocrine Clinic, a partner of Sagar Clinic. A Harvard Macy scholar, Dr. Seshadri has helped develop a competency-based integrated medical education curricula and helped frame new guidelines for the MCI. He was co-opted to the working group to develop the new undergraduate curriculum for the MCI in 2011 and is a member of the postgraduate curriculum group for endocrinology. He currently is member of the Reconciliation Board of the Medical Council of India and the Expert Committee on Curriculum Implementation and is one of the architects of the new competency-based curriculum. He has several index publications, including original work, reviews, textbook chapters, primers, and manuals. He's the editor-in-chief of Thyroid Research and Practice and associate editor Journal of Diabetes in developing countries and editorial board member of the Indian Journal of Endocrinology and Metabolism. Dr. Seshadri has been conferred with several orations and awards. He's a recipient of the P.N. Shah Oration awarded by the Endocrine Society for the year 2009, the Sam G.P. Moses Oration by the Research Society for the Study of Diabetes in India for the year 2014, and the Dr. Sindhu Pandit Oration in Medical Education. He writes a regular column on endocrinology and the arts for the Indian Journal of Endocrinology and Metabolism. We're extremely honored for having Sir amongst us. Sir, thank you so much for accepting our invitation and being amongst us. Over to you, sir.
Good morning. Thank you very much. Can I be allowed to share my screen?
Yes, sir. You're allowed to share the screen.
Can you see my screen?
Yes, sir. We can see the screen.
Good morning, and thank you for having me here. It's wonderful to meet so many of you on a Friday morning. I'm very grateful to Devaraja's Medical College in Kolar. I have a very old relationship with the university that some of you may not know. I was member of the academic board several years ago when Dr. Shetty was the Vice Chancellor. So I used to frequent Kolar quite a while. So I thought, I would put together some thoughts that have evolved over a time with me that has shaped up the way I think about medical education. and thought I will basically do a disjointed talk, that I'm not going that I'm going to put in some thoughts, and I will leave a lot of time for discussion. You will know. I will also tell you that these have been sort of bunched together, and you will not find tremendous amount of orderliness in my talk. On the other hand, I will expand on my thought process, and since many of you are educationists, please feel free to challenge them as we go along. This is my conflict of interest. I'm a member of the former Medical Council of India and current NMC expert group that helped develop the UG curriculum. So I did. This is a talk some of you have heard, these parts of this, and I did this talk initially in trying to bring about some changes in the way we teach in the clinics, and I called it 6 strategies to promote effective clinical teaching. And I've added, and these 6 strategies remain the same, and you will notice that they're intertwined into what is going on into the competency-based curriculum. And I've added this word in the new normal to this, for you to remember that this new normal is not the pandemic. I think we all think about the COVID-19 as a new normal, but actually the new normal for us education is the changes that have been mandated by the new undergraduate medical curriculum that has been released. The new normal is a competency-based education, and for the clinical area, the new normal includes a learner-doctor program, ADCOM, which most of us have understood, but I think there is a lot of things that can be done in ADCOM in the ward. They use a skills lab for the first time that saves patients from intervention and also allows observation. And of course, this loop is closed by the system of logbooks and portfolios. And of course, pandemics are a new normal, and we can expect several more pandemics. But I think I'm competent to talk about the first 5. The 6th, we should get another expert. Again, to go back, what is competency-based education or as we would like to call competency-derived education? It's an outcome-based approach to the design, implementation, assessment, and evaluation of a medical education using an organizing framework of competencies. Let me break this up, because understanding this is an important part of understanding how we reshape clinical education. One is competencies are determined. And remember, while you have this huge book of sub-competencies that are derived by the medical council, traditionally competencies are something that are end of course and not end of year. But importantly, these competencies are aligned to the mission and vision of the organization and the institution. The second, these are stated and communicated. An environment is to achieve the outcome is created. An achievement of the outcome an achievement of the outcome is ascertained and documented. So I think it's important to understand that ultimately these need to fulfill the purpose of the medical, or why medical education is being done. And from the competencies you state, which are basically outcomes, you state it, but it's not enough to state it. And it's not enough for the teachers to know that it's communicated to the learner, so that the learner becomes part of the process of achieving the competency. So if there is one big change, I would think, in terms of a competency-based education, and even in the clinical years, that a large part of attaining the competencies rests on the student himself, or the learner himself, which means that this is a shared process. Second is, you don't achieve anything unless you create an environment to achieve the outcome. And then it needs to be ascertained and documented, because unless you document it, unless you ascertain it, that you don't get it. So just for I'm sure people who have read the booklets that we have done on this will see this, but look at this part. The outcome is knowledge application. The driving force for the process is the teacher moving to a facilitator and the student in the driving seat. The content is both the student and the teacher, and the goal is knowledge application. I think that shift takes away a large bit of our traditional education, right? And of course, these we will touch upon. I'm sure there are other sessions where you can do this. So quickly, there's a shared responsibility. There is self-directed and collaborative learning. The approach is learner-centric. Importantly, there is skill acquisition and certification that needs to be done. And remember that formative assessment is integral to the learning process, that it's a continuous assessment process by which the student learns. I'll talk about a little bit about progressive increase in the complexity of learning, but again, these need to be done over a period of time. To put this together in a fashion that we can understand it, think about the student as having come from one ladder to another. As he goes, he's told and it's communicated bilaterally that these are the outcomes that he needs to get. He walks through the supermarket where all these competencies are present. He pays for it by learning it, by demonstrating it. He acquires it. The place is the structure is created in such a way that the outcome is achievable, and then there is a way of verification that is he able to do a physical examination, is he able to administer a BCG vaccine, is he able to or she able to communicate to the patient. So these are ascertained. They need not be tested all in a summative manner, but there needs to be a process of ascertaining, either by self-declaration, or by a teacher seeing it, or by a peer verifying it, or by a nurse observing it, that the person has actually gotten the thing is ascertained. So one way of ascertaining is a summative exam, but remember that there are other ways of achieving it. One is achievement of a determined standard in a periodic assessment, or documentation of acquisition of predetermined skills, aptitudes, and values. Achievement of a determined standard in a periodic assessment is an internal assessment. For a clinical exam, it could be a CEX or anything else. But documentation of acquisition of predetermined skills and attitudes and values can be done on a day-to-day basis, and then documenting it in a logbook. One example of what we do of something that has disrupted this whole system of just students going and coming is a new learner doctor method, which some of you are probably doing it, and many of you will do it. So in the medicine, surgery, pediatric, OBGYN, and ortho units during the clinical exam, the student is assigned, and he functions at least on the admission days and at least sometimes of the other days as a supervised member of the healthcare team. He participates in pre-specified team activities of patient caring and learning. He documents the progress and is assessed formatively. So this is the learner doctor method, right? Well, the way we defined it is that it's a learning program that is part of the clinical rotations in the MBBS course that is designed to provide the students a longitudinal one, immersive, which means that they are part of the learning environment, learning experience, and the care of patients. And of course, the caveat is that someone is there to supervise them, handhold them, make sure they don't fall. So you have an orientation, and a faculty member is designed for each, is assigned, who's responsible for the progress of the patient. The student becomes a part of the admission day. He's assigned to patients in the outpatient clinic. Don't overload these. They're not there for work. They're there for learning. They'll be assigned and admitted patients to interview, examine, work up, and follow, all under supervision. They're asked to remain with the admission team, but attend classes, and they participate in pre-specified team activities of care and learning that include understanding the perspective of illness, how to take a history of physical exam, communication, choose investigations, and others. What is important is that the patient is assigned to student participates in team activities, and learning responsibilities are fulfilled based on the clinical and learning context. The student documents the patient encounters, keeps a portfolio or an annexure to the logbook, has the logbook signed by a supervising physician, obtains feedback from many members of the healthcare team, and the very interesting thing is, unless the logbook that is required is submitted, he does not sit for the summative exam. Let us go back in history, because I remember this very closely as part of my medical training. Generally, it's 7:30 in the morning in the medicine OP. Then finally, a medical student runs into the OP with her friend, The assistant professor is sitting in the desk. He looks at her and gives a grunt. Meet the second year PG. He has picked up the patient for you. She grabs her back and runs to the PG. The small teaching group in the back, there's a visibly uncomfortable woman in the table. The PG walks in and says, found this good exam case for you. Chief will be here by 8:30. And as he whispers, concentrate on the aortic area. This is a multivalvular disease. They grab equipment. They start asking questions from a list. Other students join them. By 8:30, there are 30 students in the small room, including students from other levels. At 8:45 p.m., the chief walks in. He looks at the patient. The assistant comes to him, whispers multivalvular in his ears. Student moves to the front. Everyone else moves back. They grab a little notebook to write. The girls will be in the first row. The boys will just stand hovering behind them. The student starts to present, and he's interrupted, and the chief starts dictating something. I'm sure many of you remember this. And this is how many of us learned. It's true that we became doctors and wonderful doctors serving the world. And most of it is because we had amazing teachers. But what would have happened if we had actually done more? Would we have been not just amazing doctors, but also kinder doctors, better doctors, more responsive doctors? I think that is the important part of this whole thing. Problem is, clinical teaching is challenging. It's unique in the entire realm of teaching. In no other field does the nature of material demand the teacher this degree of preparedness without preparation. So clinical teachers are at a disadvantage, and they're also amazing because they're able to take a class without having to prepare for it. The problem of learning how to teach as a clinician deserves much thoughtful study. There are lack of clear objectives. There's a focus on factual recall and problem-solving skills. The teaching is usually pitched at the highest level. My teachers would invariably, I had a teacher who would come in and show 57 causes of hepatosplenomegaly without having examined the patient, but he was considered to be the most wonderful teacher. At that time, knowledge was a premium. Today, it is not, because before my teacher lists it out, the student can Google it and get another 20 more. There was passive observation than active participation of learners. Of course, there was inadequate supervision, and even in the internship era, where we did most of the work, there was absolute lack of supervision. Also, there was little opportunity for learning by doing mistakes, little opportunity for reflection and discussion. There was teaching by humiliation. And of course, from the patient point of view, it was really awful. There was no privacy, there was no respect for the dignity of patients. And of course, it had nothing to do with a formed curriculum or objectives. Understandingly, there were time pressures, there were competing demands. Patients had to be taken care of. It was opportunistic, it was not planned, and of course, students kept on increasing. Over a period of time, we have fewer patients, we are under-resourced, our environment is still not teaching friendly, and of course, teachers are never respected. So what do? If learning is the acquisition of knowledge, skills, or attitudes, and teaching is providing the opportunity for that to happen. The purpose of clinical teaching and training is the expertise in the care of the patient. Right? So clinical instruction occurs in the intellectual vicinity of the patient and focuses on either the patient or some clinical phenomenon which concerns a patient or class of patients. We all know about what are the desirable outcomes in clinical settings. We want them to have knowledge, data gathering, physical exam, prioritize data, management plan, procedural skills. But remember that there are other things that we can learn: teamwork, communication, sophistication, professional values, and how to work in a system. Also, it's a great place to learn how to grow, how to be sophisticated, how to think higher, also to realize personal goals, not just finding a spouse, of course, how to realize your potential and develop skills for lifelong learning. I want to think about 6 things that improve this, and we will again tie it back into this learner doctor and other things. One thing that we really need to do is directly observe clinical skills. Students need an environment in which their beliefs, attitudes, and behaviors can be observed, analyzed, and challenged. As Ende would say, observation is the beginning of understanding. I put this slide, and I've used this slide for the past 20 years. It's simply because this slide tells you something about how we teach. If musicians learn to play the instruments as physicians learn to interview patients, the procedure would consist of presenting lectures or maybe in a demonstration or two, the theory and mechanisms of music producing ability of the instrument, and telling him to produce a melody. The instructor would not be present to observe or listen to the student's efforts, but would be satisfied with the student's subsequent verbal report of what came out of the instrument. This is really true. I've demonstrated this in many, many workshops. People get very upset when I say this, but I think this is very true. Even in the examination, most of the time, the examiner doesn't stand next to the patient finding out whether he's taking a history or not. Instead, in most examination, the student is somewhere examining the patient. He comes and presents it. The examiner is having coffee and biscuits and has never found out whether it is a history that the student has taken from the patient, or he's just repeating something he wants to tell you. Without accurate evaluation of clinical skills, which can only be accomplished by direct observation, improvement in clinical skills of physician trainees is unlikely, and that is true. This is from 2004, but I still use this particular slide. It tells you how many of our people were never ever doing 3 skills: a history taking, a focused exam, or a complete physical. And you will notice that, and this is for residents, I can tell you this is even worse for students. One of the simple ways is a skills lab, and even in this new normal, you could still use a skills lab. For example, you could send suture materials to a student at home or have him pick it up, do it, take a video and send it back and review it. All that a skills lab does, and you don't need anything fancy, but you can have as fancy as you want. Today, haptics are available that will tell you whether the student has put the palms in the right way, whether the pressure is right, whether he or she is doing it right. On the other hand, I would think a skills lab is also useful for something as simple as taking a history, to be able to figure out how to give an informed consent, to teach a patient how to take insulin, to teach a standardized patient how to take his or her drugs. But a skills lab has just 2 features. A simple video camera is sufficient. A simple camera that allows a patient to be examined by taking questions. The patient can give you a feedback. The instructor can give you a feedback. The student himself can review his own performance and take a feedback, and then make a plan to improve it. It is something that again all of us are planning to do. It's going to be mandated in all the things. You really don't need fancy places, but what you need is fancy ideas, and make sure a simulated environment is a very, very simple way. And remember, if there's one thing, in a lot of places, even libraries are not open 24 hours. But I think a skills lab must be open 24 hours. If a student wants to go practice, he should be able to practice. Do not, use it only to show visitors. Second thing is to create a learning climate, and that comes from the physical setting. But remember, today we have learned that online settings are as important. That you could teach online many of the skills that you learn from this thing. I remember at a time I was teaching people how to percuss using a water bottle like this, and varying the amount of water, showing them how it works. Listen, it's better than starting out on a patient, simply because it teaches you how to use acoustics and others. And you could teach any number of skills. You could use standardized patients. You can do rounds in the ward with people sitting at home and watching on a Zoom platform. It just takes. Only thing is, make sure that you've taken consent from the patients to teach. Make sure that you're still very, very caring and very, very empathetic. This comes because professional role modeling is very important. Example is not the only main thing; it's the only thing. A lot of us don't give the same amount of care that we would do in our patient offices as that we don't think that's important to demonstrate in front of the student. In fact, the more you spend time with students and patients, the more you're considered as role models. In fact, one of the beauties of the Learning Doctor program that we're creating is it allows teachers to spend more time with students. And remember, it's not just being an intellectual. This is considered by most students as role models. Being non-judgmental, having clinical competency and enthusiasm were the 3 most important. How much you know Harrison's or Davidson's or Bailey and Love really didn't matter to the students. It's also important that we learn how, in a clinical environment, to challenge and support. If we don't challenge and we don't support, people don't grow. If we challenge is low and the support is high, then everyone thinks the same way. On the other hand, the challenge is high and the support is low, there's fear and retreat. Really you want to be asking the right questions, and you also want to be supporting them. So challenging them, allowing them to do self-directed learning, or looking it up and coming back. Don't resist the temptation to give the answers. Look it up and come back, but don't make it impossible to find out. But when they come back, be able to support them, feed them back, and say, you've done a great job. Why don't you look up some more? So that brings us to is moving from cognition to behavior. One of the important things that we should start doing in clinical settings is to create behavior that becomes this thing. And this is done by promoting clinical reasoning. I won't spend too much time on this, but remember that learning in a context is very, very important for the evolution of knowledge. So I talked about these two, and as you listen to this talk, I'm sure you understand what are the elements of these new that are coming into this. And of course, that brings us to the questions. Self-directed learning is determined also by the questions that you do. 90% of our questions in an examination in the ward and every other place starts with what? It needs to go up to why, how, and importantly, why not? When you ask why, they will look further. When you ask why not, they may end up doing research. Or what if this would happen? What if the ejection fraction had changed? What would be the symptoms? You know what? This patient's symptoms has changed in the last few days. What do you think is happening to this person? You could give the answers. That's like giving people fish. Or you could provide them questions and the tools to find the answers. That's providing a fish hook and teaching them how to fish. We ask the wrong number. We are very bad in asking questions. We either keep on asking questions, they are double-barreled. A lot of times in examinations I've seen that the examiner is asking questions to find out what the student doesn't know, and worse, to show that he knows how to ask the most wonderful questions. And I've seen the flourish looking at the other examiner saying, "Do you know what a great question I asked?" And of course, you would never wait to pause because you want recall and you don't want the patient to think. These are things we don't want to do. We want it, as teachers, one of the things that we have to learn in the new normal is to ask the right question. And that's really how self-directed learning grows. That's how competencies are achieved. One important part of the clinical learning process and how self-directed learning works is reflection. Reflection is an internal process that individuals use to refine their understanding of an experience. And reflection is the key to teaching in the learner's student-doctor relationship. It's very, very important because you will get so many situations, a patient dying, a patient doing well in spite of your efforts, a patient not wanting your treatment. Each of these are semantic movements to promote reflection. The student is getting an experience that they will never forget. And our job is to make sure that they have thought about it. It provides context, provides meaning to the experience, it fosters lifelong learning. There is usually a trigger event, something as the student coming back the next day morning to see the patient and write a note, but the patient dead. And that's a trigger event. Analyze the feelings and find out what went happen and develop a perspective of it. What happened, what went well, what did not go well, what could we have done? If it occurs again, what should we do? Is the sheet anchor of reflection. And it's the greatest tool that's ever been invented to help students and people grow. My pet area, simply because if there was one contribution I did make to the whole curriculum process, I would call it AdCom. And you know, it's that the clinical arena is a place to teach the human dimensions of clinical care. There are skills, communications, values, attitudes, and responsiveness. The student comes in thinking for the examination, And he's thinking about the examination, and he thinks knowledge is important. A doctor thinks that skills are even more important and communications are important. But remember what patients value. They value communication, responsiveness, attitudes, and values even more than they value knowledge and sometimes skills. It's very, very important that the hidden curriculum is formalized. A lot of us think that AdCom must be done in only those 2 hours that are there. But remember that there are a lot of AdCom competencies that are achievable in the clinical setting, right? And it is important to make sure that you know what, I'm going to talk to this patient. Why don't you observe me and tell me where I went wrong? Can I observe you talking to this patient? Can I observe you communicating how to give the injection? Can I observe you communicating how to take the medication? Right? I think this is very important. That the clinical care setting is used not just to give knowledge, not just to observe people getting skills as how to do a lumbar puncture or how to do a thing, but also to talk to a patient, to be able to listen, to be able to understand, to be able to improve. I think the new medical curriculum with its student doctor program or the logbook or the self-directed learning has created this culture where we can bring a well-rounded student. The secret of the care of the patient is in caring for the patient. Francis will keep it, but I think you can really teach so many how not to talk in rounds, how not to communicate for example, in an elevator, how to use your eyes, how to communicate with a mask on, how to use your eyes to communicate with the mask, how to observe, but importantly, how to be a human and how to be self-aware. Lastly, of course, provide good feedback. I don't want to spend time on this, but it's very, very important. But the important thing is never give feedback in front of 20 people. Feedback presents information, it does not judge. Can I give it to you? Again, go through the same thing. But important is to pull this patient aside. I watched you talk to this patient. It was very nice. This is what you did well. Can you tell me what you did well? Can you tell me what you did not do so well? Can I give you a few more points? What do you think we can do to improve? It doesn't require a big thing. It requires a little amount of commitment from all of us. This is an important part of the whole clinical learning process. I won't spend time on this, but move back on to our Learner Doctor program. This includes data gathering in a meaningful fashion as integral to the patient care. For example, history and physical. Includes critical thinking and analysis, where you record analysis, being part of the decision making, talking to patients about cost, developing a management plan, choosing the appropriate therapy that is available in the system, the insurance, the thing, or the patient. Ability to communicate and discuss the diagnosis and treatment plan. Be part of a multidisciplinary team, not just with the doctors who think that they're gods, but actually working with nurses, with nutritionists, with people who are doing physiotherapy, teaching how to do how to use an inhaler, right? Work and chart review, find out how many patients have had a blood pressure measure in an OP to see how many patients have had their blood pressures measured and their blood pressures are normal. Take an adherence questionnaire. There is so much that we can do. This brings in, and for each of this, go back and learn about it. Tell me something brief tomorrow morning. Write it up in your portfolio. Let me put this into your log. Why don't you reflect on what happened to this patient yesterday? This patient refused to have surgery because she couldn't afford it. Why don't you talk to me about this? Think about the socioeconomic consequences of not having the surgery. This is how we create a learning environment. But it's important that the institution gets involved in this. Choose the competencies that should be acquired in each rotation. What activities should these competencies address? Importantly, train faculty, orient students, make sure that both of them are important and both of them are responsible for the care. Then create a process of feedback. So I've given you examples. This is there in the booklet. These are the competencies that can be done in the second year, the third year, part 2. These can increase in detail and complexity of task. Think about things that you never ask students to do. To get a CBG, to talk to them about diabetes, to look at the indent for the therapeutic drugs, to take part in phlebotomy, to take part in cultures, to go with the patient to get an MRI, to talk to the radiologist and come back to the results. Each of these are important. Each of them helps them become a doctor who is responsive, who is competent, who is knowledgeable, who is skillful, and more importantly, humane. These are examples of how to do different things. I won't spend too much time on it, but it's important to understand that these have to be assessed. Some of these are just noted. Some of these are questioned. Some of these are transferred to the internal exam. Some of these are transferred to the final exam. That depends on how critical it is. The more critical it is, the more it should have formative assessment. The more critical it is, the more it should have certification. But clearly, we have moved away from just repeating my 57 causes of hepatosplenomegaly to be able to perform and demonstrate how it is performed, to choose the right investigations, to make a reasonable assessment, and importantly, to communicate with the patient. That is a change that we need to do. And that is a change that the new curriculum, the new guidelines facilitate. And of course, will our students do it? If you insist on them to do it, to log it, to correct it, and not just tick it, they will do it. Because if they're attending the final exam, depends on it. And some point of time, I promise you that they have to carry this logbook into their post-graduation. And maybe someday a hospital that's going to credential them is going to say, can I look at your undergraduate logbook? I think we need to tell students these, that their lifelong performance starts from the day they enter medical school, the day that they start seeing patients, and what they have done will count till the day they retire. We need to start doing these things more and more. And that's really all it is. What I've tried to do is intertwine some examples of what I think are important into some parts of the new curriculum. And I think I've taken only 40 minutes to do this. I will spend enough time with all of you in answering questions. And I know I've created more questions than answers. But that's really how it has to be. In times of profound change, the learners inherit the earth, while the learned find themselves beautifully equipped to deal with a world that no longer exists. I hope, though disjointed, I hope this was useful for you. I hope we can top up the learning with a lot of questions and discussion. I'm also keen to hear all your views, your experiences. My suggestion is also not to get focused on the difficulties of teachers. They are there and they need to be sorted out. But how can we together make it better for our students? And after all, the reason why we became teachers is because we wanted to create a generation of students that are much better than us. Thank you so much. Vinuta, I'm done.
Sir, can you hear me?
Yes.
Thank you so much for that elaborate deliberation, sir. Let me ask the participants, should they leave their queries in the chat box, or can they raise their hands and
They can do anything they want.
Okay, thank you so much, sir. I think many of them have queries regarding the student doctor program. So participants can either raise their hands or leave your name in the, you can ask your questions in the chat box. You can unmute yourself and ask. Unmute. Dr. Jyoti Nagmoti. Yes, Dr. Jyoti, you can unmute and you can ask the question.
Hello, sir.
Yes, Jyoti, you're audible.
Thank you, sir. Thank you for a very elaborate session on how best we can learn and teach the clinical skills in the new norm. That was very useful indeed. I just wanted to know, sir, that what is the role of e-portfolio for undergraduates, since it is not mentioned, rather it is restricted to the e-logbooks for undergraduates. Can you just elaborate on that, sir?
Sir, you're muted, sir. You have to unmute.
So maybe, you should let me be unmuted. Okay. So very simple. Actually, it's not correct that it is not allowed. What is mandated is a logbook. Okay. And because we don't want to confuse people saying that a portfolio is mandatory, whatever is documented in the logbook is supported by a document. This document can be an annexure to the logbook. It can be a regular portfolio. It can be an e-portfolio. So the way we have reimagined this is that the logbook is the sheet anchor of the clinical and other rotations, because it documents patient experiences as well as other experiences that the institution that are required. So the logbook is a single line entry, right? That single line entry is supported by another evidence. For example, let us say I talked about I have counseled a patient on grief, right? That is a logbook entry. The student's reflection is part of the, either you can call it the annexure to the logbook or a e-portfolio or a regular portfolio. So the portfolio is present. We encourage it. But remember that we are dealing with 477 medical colleges, each of which may not be at the same advanced level that some of you are. So we have a leveling field saying, look, the logbook is mandatory, but we encourage you to have an annexure or a portfolio. So clearly present.
Sir, Jyoti, yeah. Sir, this is from our registrar, who is also a pediatrician, Dr. Kana Prasad. To implement, he says he congratulates you for this excellent session. To implement this new norm, it will require a complete change in attitude of teachers to become lifelong learners first, and then teach the changes in the new norm. So how do we bring about this is his question. Your comments on this.
So absolutely, remember for the students, it's not a new curriculum. Everyone talks about new curriculum for students. For the students, it's only their curriculum. It's only for teachers, it's a new curriculum, first. Second is, we've all gone through medical school wanting this, isn't it? And now that we are teachers, there is an inherent resistance for us to change. So the important thing is for us to change ourselves. But that comes from the organization itself and the culture that the organization creates. A lot of us can strategize, but remember, culture eats strategy for breakfast. And how do you change culture? Culture is changed by the head of the institution owning the process. If the head, remember, fish also rots from the top. If the head owns the process and insists that this is how we will do it, then the organization will change. Some people will run and change. Some people will walk and change. Some people will watch and change. A few will never change. But over a period of time, the majority will change. I remember, in the many years that have gone by, when we talked about change, we will change when the MCI changes. Look, the MCI has changed, and the MCI has also changed the curriculum now. So we can't keep complaining about something else changing. We need to change internally, and that comes from all of us doing it together.
Thank you, sir. Sir, Dr. Varsha, our geriatrician, has a question. Varsha, you can go ahead. Unmute, Varsha. Unmute and ask the question. Varsha?
Hello.
Yes, we can hear you. Ask Varsha.
It was something similar what Prasad sir asked, I believe. I was just wondering, we are in a transition phase of modern and old teaching techniques, sir. It's very challenging for people because we have learned through the old methods. So first we need to adapt the modern methods to teach to the young generation. So it's very challenging. Is there any input you would like to share with us, sir? because you have came through the old teaching techniques, sir. So, and you are teaching the modern technique to the students right now. So what would be the challenge and what would be the easy way to take it forward?
So it's never easy for an aging brain to make changes, right? But the first thing is to recognize that we are not the repository of knowledge for everything that is great. The students who are there are also equally responsible and equally wonderful in learning. And all we have to do sometimes is to do as a bicycle learner does. You don't keep pushing the bicycle all the time. You let the student, you let the bicycle learner get onto the bicycle and you follow them. And at some point of time, they are good enough to go on their own. You are there to prevent them from falling down. Our problem is we think we have to do everything. In fact, let me give you a very bad example. A lot of times we say, but we have to cover the portions, sir. We have to cover the syllabus. The truth is you have to uncover minds, not to cover syllabuses. Our mindset needs to change from one of knowing everything to joining the journey of the student in learning. That means taking up a back seat, asking the right questions, but not necessarily trying to spit chewed food into their mouths. Once we start doing this and saying, look, you're responsible. Sir, I have not finished my logbook. I understand. I'm willing to come back tomorrow morning. Go finish your work and come. But there is no way I'm going to let you sit for this examination till you have learned how to administer an informed consent. Place the accountability on the students. Provide the environment to do it, but resist the temptation to do two things. One, to do it for them. The second is to have two rules for two different people. If they find that you are not fair, they will not respect you. On the other hand, if you tell all of them, look, this is the second thing that we don't do is we don't disclose. We don't say that these are the things that you need to know. At the beginning of the year, there needs to be a timetable. In the student's handbook, there needs to be all the competencies. They probably need to have an app that says, after they finish each competency they have acquired, they have an ability for them to tick it. It's like going, no, you have a checklist. Have you finished it? If you not finished it, stay back and do it. Be fair. Give them the respect that they deserve. Teaching with respect and respecting students is the first way to change our mindset. Cultivate a lot of respect for your learners and things will change. I think if I were to give you just one piece of advice today, is start respecting students as responsible for their own learning. Thank you.
Thank you so much, sir. I think this allows room for us to reflect the faculty, especially in this transition stage. So we have a question from Dr. Ravish, HOD of Medicine. Dr. Ravish,
yeah,
you can ask.
Sir, good morning, sir. It was an excellent talk. I'm Dr. Ravish, HOD of Medicine. Hello, can you hear me, sir?
Sir, you have muted.
Yes,
You
sir.
have unmuted.
I have unmuted, madam.
No, Dr. Krishna Seshadri sir has muted himself. Sir?
Hello?
Yes.
Please, I think what is happening is the host is muting everyone and he's muting me also.
No.
Good morning, sir. I'm Dr. Ravish, HOD of Medicine, sir.
Yes.
It was an excellent talk, sir. It was an excellent lecture. Sir, I have a small clarification to be made. Here, our problem is I'm a clinician. Basically, we are teaching general medicine. And suppose we are in the hospital and we get lots of students at a time. No, sir, from third term to the ninth term, around 30 to 40 students in one department. So is it not that very difficult to observe each one every day and asking this, what is the solution for this, sir? How to go ahead?
How many PGs do you have? How many assistants do you have?
One PG in each unit, sir. So it will be around 8 PGs per day, per year.
Right. So the way to look at it is, one is, first to remove this hierarchy that the chief, this chief assistant associate hierarchy needs to go away.
Yes, sir.
You're a team,
yes,
right?
Sir.
And every member of the team can be assigned a student or two.
Yeah.
That's really what the learner doctor does to you.
Yeah.
Someone can tag along with a PG and there's nothing wrong with it as long as, it's co-signed by an assistant professor.
Okay. Right, sir.
I think, to teach how to take a CBG,
yeah,
or how to place a urinary catheter I'm sure the PG will do it better than me.
Correct.
Right?
Yeah, right.
We just have to adopt different roles. All we have to do is to humble ourselves a little more. A lot of times we think that the world revolves around on our head, and we are the purveyors of it all. Unfortunately, the world will run with us, without us, and in spite of us.
Yeah.
And the moment we stop taking ourselves so seriously and spread the responsibility around, and remember also that responsibility belongs to the student also. Because we think that the responsibility is on our head, this becomes a huge issue. My suggestion is think of all the members in your team as being responsible for patient care.
So we can
If there are 30 people in your department, each one can help a student.
Yeah, that's what, sir. We can allow even the PGs, SRs, and the assistant professors to assist the students. Is that okay, sir?
Absolutely. As long as, let me give you the caveat.
Yeah. So no, we have
Make sure.
But what is right or wrong?
You are the signing authority.
Yes, sir. Thank you, sir.
You can assign, but as long as you supervise.
Yes, sir. We will be supervising. Thank you, sir.
Thank you, sir. Now we have Dr. Jarina's question. How we can proceed from teaching factual knowledge to problem solving as a teacher is her question.
Okay, there's a mute issue here. Anyway, so it's actually interesting. So I address this in my talk. I don't know if I rushed through it. It's a way you ask questions. From what, move away to how, to why not, and what if. That's problem solving, right? What are the 5 causes? What are the 10 causes? What are the 10 ways? What are the 15 ways? No. Why do you think this patient has fever? That's true, but this patient has fever only in the afternoon. Why do you think that's happening? Do you think that the kind of bacteria that is involved or the viruses or fungi have different patterns of fever? Do you think that's why this is happening? That's a great point that you make. But what if this were not a virus? Do you think something that this patient has taken in the past few days be responsible for this? See, this whole idea, the whole part of clinical medicine teaching is learning how to ask the question in a way that the student is stimulated, but also has the right amount of support. A lot of times we either ask questions that are so dead easy that the student is not interested because it doesn't challenge him. That the reason that students don't come to classes is because there is not enough challenge for them. On the other hand, we ask impossible questions for which, remember also, a question need not have an answer on the same day. You know what, this is something that both you and I should think about. Why don't we talk about it in rounds tomorrow morning? You know what, in the coffee break tomorrow, tell me what is it that you looked up? Oh, that's a wonderful point. Okay, what I'm trying to do is I'm trying to recreate a conversation for you to move away from factual to problem-based learning. I hope you get the idea. Yeah. It's by lowering ourselves to their level, talking to them instead of talking down to them, and then working with us. Does it make sense? I can expand on this more if you want me to.
Yes, I think the whole idea is to unlearn the way in which, as teachers, we used to deal with asking questions, and there's a lot of training required for us teachers to adapt to the new program and sort of do this partnership type of learning, sir. So I think it was good that this translation into how to ask questions is something that clinicians will think about.
So there's a way to learn this. Get into a skills lab. I'm someone who believes a lot in a communications lab, right? Have one of your colleagues become a student, have a camera, right? And then actually test yourself doing this. Take a case scenario, try asking questions to your colleague, and then review it on a video and see how you're doing. A lot of us will be surprised at how condescending some of us can be. Including me, I'm telling you, this is how I learn. I learned by being an arrogant teacher, and someone showing me, look, your students don't like you because you're so arrogant. Lowering ourselves and humbling ourselves, and there's no. It's a question of just getting in and learning from our colleagues and say, why don't you, or I was very interested, how many of you would let another person come into your classroom and observe you, or your clinic and observe you? Take your colleague and say, I'm going to take a class today. I'm trying to ask better questions. Why don't you come and observe and then give me a feedback? The ability to continue to change ourselves is the only way to become better. Thank you.
Thank you, sir. So there's one question from Dr. Harish Reddy. Live patient contact is an irreplaceable tenet of clinical teaching, but extraordinary times demand exceptional measures. Sir, can minimal clinical exposure supplemented with simulated patients be an acceptable alternative? I think you provided partly the answer in your previous question.
Absolutely, you can do that. Remember that in this day and age, and also given the amount of litigation, given this thing, every institution must spend time developing standardized patients. This is one. Second, what this epidemic has shown us is that there are so many things that we can do remotely. You can do skills remotely. You can learn to auscultate remotely. You can learn to talk to patients remotely. You can learn how to communicate remotely. It isn't expensive. I was just seeing that a haptic palpator of the abdomen today, that's hyper real, is about $1,100. Okay, that's 60,000 rupees or 80,000 rupees. A haptic palpator at 80,000 rupees is a steal, the kind of technology it has. All we need to do is to open ourselves. A lot of times institutions spend money on marble and granite and fancy stuff as a way. A lot of times you see that. Actually, you need to start investing in things like this. A communications lab, with just 4 rooms and 2 video cameras. It can be as bad as, it's nice if you have a DSLR that captures emotion, but even if the 2 cell phones that are connected, it still makes a difference. Start using skills labs to improve faculty confidence, not just student performance, but faculty confidence. Once you start going into skills lab and saying, let's observe me as I teach how to take an informed consent, observe me as I teach how to ask questions, observe me as I teach how to teach communication. Work with your colleagues. I think we have a lot more to learn than our students. And we can do it.
Thank you, sir. We have a question from Dr. Prabhakar, Professor of Medicine. He asks, don't you think as our input of students is highly variable in terms of quality, in terms of competitiveness, is it a big handicap in this process?
Absolutely not. You want the diversity. It's easy to, an intelligent student who's at the top of the class doesn't need you. He absolutely doesn't need you. He will do well with your help, without your help, in spite of your help. The challenge is to take different inputs, different languages, different cultures, different diversities, different backgrounds, and then helping them achieve a certain degree of competency. At the same time, retaining their diversity and background, because that's really what medicine is all about. In fact, if I had anything to do with it, I would allow people from the engineering streams, from the architectural streams, from other streams also to come into medicine, because it strengthens medicine. But clearly, if you want only a class of really amazing students, then you don't need teachers.
You are actually talking about academic flexibility, which is something that even UGC is talking about. So. And one question from Professor Dr. M. Chandrasekhar. How will you help to resolve the concerns of others about the process change from traditional to competency-based education? How did you measure success and ensure compliance for the new process?
By keeping it transparent, but by making sure that every stakeholder is addressed, by making sure these inputs are fed back into it, by making sure that there's a fair process to evaluate it, and be ready to accept if mistakes are made. I think transparency is the beginning of accountability. And accountability is the only way to ensure or allay fears of others. There will be naysayers always, but I think it's important that we address the needs of our students, the needs of society. Society wants doctors that are more responsive. Society wants doctors that are more communicative. Society wants doctors that are more competent. And I think that's what people try to do. However, it's also important that we make sure that we don't show that our students are not guinea pigs in this process. So it is important that we get feedbacks, that we evaluate, and are willing to change if mistakes have been made.
I have a question from Director of Academics, Dr. Sarala. With respect to self-directed learning, how do we relate it in this process?
Oh, absolutely. So remember, self-directed learning starts when the student has a certain amount of responsibility in his or her own learning. So the most important way to create self-directed learning is to inspire them to learn on their own, and then provide them time for people to learn. So we notice a lot of time in Saturdays have been left for self-directed learning. So space has been created in the curriculum for self-directed learning. That could include assignments, that could include looking up questions, that could include participating. Remember that one way I used to do before we created AdCom, I developed a program called ProDev in my old avatar, in my old institution. One of the ways that a medical, legal, or ethical cases we solved was you could go learn about it, search about it, but one of the things is to also ask other clinicians about it and come back. Going and asking other people and getting their opinion is also important. But clearly, a self-directed reflection, this is one. The second thing is reflection is the starting of self-directed learning. That includes, when a student is able to assess that this is something that is important for him to understand before he solves a problem, then he will learn more on his own. The teachers must stop one thing, and let me elaborate on this. You give a child Pharax or Nestum. You try to give it to an adult, he will spit it. Why? Because you want the smell of food, you want the placement of food, you want the aroma, you want the ambience that goes with eating food. Similarly, with learning for an adult, you don't want notes, you want the ambience of learning. You create the ambience and you provide the stimulus and they will learn. So as I said, teaching is creating an environment for students to learn. I think that's something we have to work with. So remember, even in the Upanishad, that Satyakama Jabali went to his teacher and asked a question. The teacher didn't say, gave him the answer, and he said tapaha. And he came back, and then he gave the answer, and then he asked another question, and again he said tapaha. And that's really what happened. I don't know if you remember the story, but that's really what happened. It is a journey of self-discovery and learning. And all we are there is to just guide them along with. Okay.
So I think as faculty, we should know where to stop and where to let students take the few steps. So that is something I don't know how, does it come by practice or conscious working on these skills, sir? Like, how do you think the clinicians should really ensure that they think the students are not motivated enough? So, and so they think they have to handhold. So where do they draw a line?
Where do they draw the line? First thing is to draw the line for ourselves. I'll give you an example. I remember this very, very well. I was teaching how to do a small group discussion. We had this video. And I remember that I suddenly forgot the name of a student. The camera had panned to her, and I could see that change in the expression when I didn't know her name. The reason I'm bringing this up is, remember that we're dealing with adults. The most important thing is to start learning to respect our students. We don't go and impose our views on people that we respect. We listen and have a discussion. First, cultivate a respect for the student. Second, you don't need to be the most knowledgeable person in the room, and you don't need to have all the answers. I think that is the second part. The third is reflect. Reflect at the end of the class, reflect. What did I do well? What did I not do well? What could I have done better? Get feedback. Call a student and say, you know what, I want to talk to you. You had class with me today. Where do you think I can improve? Are you brave enough to do this? You can't do that. Call a colleague, as I said. Get them into your class. Tell me how to do this better. It will come. But it comes from respecting, it starts by respecting our students as someone who has a brain of their own, has a mind of their own, has a will of their own, and are willing to learn. A lot of times students are not motivated because they are bored with you. You don't challenge them. You are repeating the same thing that is in the textbook that they have read yesterday, or they know that they can read just before the examination. You are not remember, knowledge is not going to get you anywhere. Don't impart knowledge, impart wisdom. They are here for you to learn how to do things differently and better. Not for you to cut and paste slides from the textbook and project it on the board. The moment you realize that, things will change.
Yes. I think I'll take 4 more questions, sir, because it's like there are too many. Is it okay, sir? Can we have for next 10 minutes?
I'm okay. I'm okay.
So there's one question by Dr. Arun Dhangana. Sir, will problem-based learning be effective in this format for students to learn? Is his question.
See, can I tell you something? I think we have gone far ahead of problem-based learning. The traditional PBL that was done in several schools in Canada and others, that required that a problem be given and the teacher only be a facilitator, and the students learn on their own. And remember that they did quite well. In terms of exam performance, in terms of others, there wasn't much of a difference. Most of us prefer a hybrid model where a problem is created, a problem is used, and the student and we both share the journey. I think there's a lot more happiness in sharing the journey. There are some places where you need to come in. But a PBL kind of approach where you're a facilitator is exceptionally useful. But should we move to PBL? I think we've crossed that bridge, and that bridge is not really useful for many of us.
There's one more question by Dr. Chandrasekhar. What method or tools of mentorship did you use to demonstrate desired behavior in a student?
Okay, it's several ways. A mentor. Remember, there's a difference between a mentor and a tutor. A mentor is someone who looks after the welfare of the student, is not directly connected to the day-to-day working of the student. Right? I think it's very important. A mentor is an informal relationship in many ways. But to be able to mentor students in the loose sense, first is, of course, to be a role model, to be impeccable. I mean, if you aren't a change, you can't find the change. But you also don't want a student to be in your mold. You want him to develop his or her individuality, but at the same time have your path to success. That they learn how to do things somewhat your way, but with their own style. It's a balance. We get it over a period of time. That you allow the people under your care that wiggle or lay room to become their own. The important thing is not to be threatened by success. A lot of times, we don't like our students to be smarter than us. In fact, we want them to be smarter than us. It's a mentality that comes as we get older. We learn to let go. We learn to watch their success, and we are there to prevent them from falling down. I think it takes time, but mentoring ultimately becomes an art. But the simple principles are keeping the benefit of the student as the first thing in our mind, and having that our mission is what makes you a great mentor.
Sir, Dr. Prabhakar, would you like to ask the question? Your hands are raised. Professor of Medicine from our college. Dr. Prabhakar. Yes, sir. You can go ahead.
Sir, it was excellent talk, sir. It was very good learning experience.
So I can't hear you.
Our endocrine and diabetic needs.
Prabhakar said you have to be louder. Not
Hello.
clear. Your voice is not very clear.
Hello. Hello. Hello.
Yes, sir.
Can you hear me, sir?
Yes, we can hear
Now?
you. Please go ahead.
Very well, very well.
Hello.
Continue with the question, sir. We can hear you.
So good morning, sir. Good morning, sir. So good morning, sir.
Yeah, good morning.
Hi. It was an excellent talk, sir.
So I think you can leave your question in the chat box, sir. We are not able to hear you properly. So if you can leave the question in the chat box, I will ask the same.
It's an
Can't hear
excellent
you, sir.
talk, sir. Actually, I had a lot of your talks
Prabhakar said, I think you have to leave your
during
question in the chat box.
our good morning, sir. I heard a lot of your talks in diabetic and endocrine medicine. In fact, it's my pleasure to meet you at this time. Okay.
Vinita, I think he's stopped.
Yeah, I will take his question in the chat box. Sir. Dr. Raghavendra Prasad, you have a question? And the Professor of Medicine, sir. Dr. Raghavendra Prasad, if you have a question, you can ask. Sir.
Okay.
Dr. Raghavendra Prasad? Okay. So there's one question. So won't it be an exaggeration to say that we should use the process of equity rather than equality to get the justice get delivered to the new students?
It's a play in words. I think the Sanskrit words that are equivalent to this are samatvaha and samabhavaha. You can't get samatvaha. It's very difficult as much as people talk about it because there will be differences between people. But for a teacher, samabhavaha is very important. That we recognize that everyone has a purpose, a mission, and drive, and they need to fulfill their personal and professional aspirations. And when a teacher adapts those, then of course justice is served. Equity is somewhat very difficult simply because each person have their own pace of learning, what they achieve, what they do. But irrespective, the teacher's job is to make sure that these people achieve their potential and maybe higher by being a beacon of light, by being a stimulus, by actually, what would I call a great teacher? A great teacher is one who asks the best questions. I think that's really the truth.
Thank you, sir. Very well explained. So there's one last question. For new teaching and learning methods and assessment for this scenario, faculty development is being a big challenge. How do we address this issue?
By creating a need for change, and by emphasizing the need for change, by talking about it, by communicating it, by also putting a mirror in front of us. That is when, asking students to give honest feedback about how their teachers are. And I think if you can't change, then we will be left behind. Remember, we are all sitting and complaining about students not attending class, not being interested in it, not wanting to be part of our classes. And we keep blaming them. We blame them, their phones, their fathers, the fact that they have a lot of money and we don't, that they come in Mercedes Benzes and we come in Maruti cars. The actual truth is that they have gone ahead and we are left behind. We need to catch up. The way to catch up is by changing ourselves. By moving away from being purveyors of knowledge to people who help them discover their future. It's difficult. I mean, it sounds nice in a upanyasa like this. But what it is a conscious effort to make ourselves better and better and better. And I think that is the eternity of this whole thing. Remember that you didn't need regulations to create a new culture of students. Regulations help, but they're really not necessary. A good institution, a good culture of learning, humility in our parts, being able to work together, more importantly, keeping the welfare of our community ahead of us, are things that will ultimately help us change. And the very fact that you all chose to come here on a Friday morning, leaving your busy work, itself tells you that you're ready to change. You just have to take it forward.
Thank you for that philosophical perspective, sir. So before we wind up, one question from Ishwaran: is it okay to implement CBME at once instead of in stages? I don't know if you're the right person to whom the question is addressed. So his concern is, can we do it?
Well, I guess I am, because I was part of the decision making in saying it should not be done at once. So we didn't want 5 years to have CBME the same way, same thing.
I think the mic, your mic is like cracking up.
Probably. Can you hear me now?
Yeah, with an echo, but we can.
Yeah. Okay. So the important thing to remember is that, I mean, we were part of the decision making. The decision that we thought was that a new batch will progress with CBME. That you don't impose it on the older batches, but the new curriculum gets into as a batch grows up. The reason is not for the students, but the reason is for the faculty, to give them time to adapt to the new learning environment. So yeah, I guess that's the answer.
Yes. Thank you, sir. That inspires us to like get into this new process. So thank you so much for spending time with us and enlightening us and educating us in the first place. And this was some gray area where all of us, like the rest of the topics of CBME, like faculty felt they have a hang of it. But this specific domain, thank you so much for clearing even the myths, I can say, because there were a lot of apprehensions as to how do we go about it. Thank you so much for giving us direction, sir. And I really, Friday morning, as you told, you consented and have been pestering you. Thank you so much. And
No. I'm happy to come back anytime. Just give me a little notice, and I'm very, very happy to share and be part of this discussion. This is amazing. So wonderful to see all of you. And thank you for all the effort that each of you have put into making the lives of our students and ultimately our patients better. A lot of times, it is not appreciated, but I remember that what you're doing is just amazing. Thank you, everyone.
thank you, sir. Thank you so much. And we seek continuous collaboration with you in this aspect, sir. Thank you so much, sir. Thank you. I thank all the participants for having been with us. And thank you all. Continue to participate in our monthly webinars. Thank you.